Does the microphone work? Perfectly. So I'm sorry to give you not a native American or English or Aussie accent, but this horrible French accent. Sorry for this. We have to deal with whole body ultrasound centered on the lung. Well, it's not my first lecture, but each lecture is an adventure, and this one is a big adventure. I was advised not to talk of technical, scientific things, but rather to, and Victoria advised me, just to tell my life. So I will tell you the life of a happy researcher, because when you succeed your research, you have one great opportunity to make the world a small family. And that is really highly exciting. So if we stick to the title, I should say technical words. The lecture should be not emotional, very technical, not spectacular, and I guess not in the smack spirit. But the message anyway should be, I will try to show that my past, which is also my present, could be your future. So listen well, because there are technical points at the end. Let's take the example of the Sesame protocol. That was a rather young lady who had pneumonia. Her name was Janet, cardiac arrest in the ward. And this is an example of the Sesame protocol. And you can see that we have a narrow machine from 1992, which switched on 7 seconds. It's old, but this is the fastest machine in the world. And one probe for a whole body approach. You see that the lung is in number 1 and the heart last. Let's do it. Top. Left lung, lung sliding, fine, no pneumothorax. Right lung, top. Oh, I see a big anomaly. We enlarge the image, and we see clearly abolition of lung sliding. That makes the stratosphere sign with the repetition of the pleural, the A-line sign, that is the A' profile of the blue protocol. That is the sign fully sensitive to pneumothorax in a few seconds. And it was just an introduction to holistic ultrasound, that is how a direct analysis to the lung gives more information than the traditional analysis of the heart, traditional for those who use ultrasound in cardiac arrest today. It's not everybody. Would you like to know when and where could we make this diagnosis possible? Let us make a travel 20 years back and try to imagine the silence of the desert. It was in Sahara, January 1996. But instead of the silence, you have a noisy sound of bikes, trucks, helicopters, airplanes. If I had the video, I could make some Wagner music or Coppola tunes, so that's a spectacular image. That was the Dakar rally. Imagine the noise. And we have a crash with a biker. And how do you want to diagnose a pneumothorax with your stethoscope in that harm, in that chaos? But we did that because we have the visual approach. And maybe it was the first extra-hospital ultrasound, I don't know, but it happened in January 1996 with that very cute machine from Dymax, Pittsburgh. You see that I asked them 2 years before if they could give us the machine for the event, and it was a rather honest one, but it is the prehistory. I am very happy because I can do my 3 patients, that is critical medicine, critical ultrasound and airplanes in one activity that is medical retrievals that I do sometimes. I do one tomorrow, precisely. And look at these strange birds where we fly. That's the Piaggio 180. Amazing machine, so I don't insist because time is running. And for these missions, we use pocket machines because we are in the sky. Every centimeter square counts. We have even an OC machine, the signals. Well, but what was the story before? How did we make this transgression? We have to make a step back of 11 years. And that is the night of a quiet hospital in 1985. I began intensive care, medical intensive care. It was my first 9 shifts, and I had the privilege to be the pilot of this gigantic hospital that is very proud to achieve this and completely scared, as you know, you all know that. And in March, no, it was April 85, we had a patient, his name was Harry, with that white lungs. He was worsening hour after hour. I was alone. I was thinking maybe of a pleural tamponade, but if you insert the needle and if it is not the diagnosis, you make big noise. I wait midnight, time for the attack. The target is the radiology department, which was empty. There was no defender. And today, there are not many defenders after midnight. I must do fast, that is, going without noise, unplugging the machine, going back to the ICU, making the transgression. Result, wow. Okay, that was pleural tamponade. Inserting the needle was beneficial for the patient. Good work. But please, consider that this was completely irregular, forbidden. So I ask you all, that's a secret, please don't tell to anybody what happened. Thank you. And then came the light, and came the era where the doctors were understanding the power of ultrasound. I am so glad to have all this family, including those who are here today. That's an acknowledgement. So the idea was simple, but somebody can tell me, hey, professor, how did you dare to take an ultrasound machine? You were not radiologist. You took a risk. Let's take 2 years back. And just I was student, I fell in love with ultrasound. I saw examination and I saw, wow, what a scary but extraordinary tool. We can look the inside, that's visual medicine. So I learned the technique in a radiology department the year after, and the year after was the time where I began my curriculum and the transgression was made. 4 years of underground clandestine work before I came at Ambroise Paré Hospital. And here, I had the opportunity to work with François Jardin. He had the echo machine on site for cardiac assessments. I was at the best place, he was the first one, best place for defining critical ultrasound as a point of care tool, philosophy. So please, we are not expert in lung ultrasound. What we did was in our night shifts, instead of going to bed, we scanned our patients with the question how to be useful to the patient. And day by day, the field of traditional ultrasound was enriched by the subclavian venous cannulation, published 1991, the search for blood in the abdomen in trauma. I didn't find a flashy acronym, I'm sorry for that. published 1991. The optic nerve, 1992, inferior caval vein, etc. But what we did was inserting the probe everywhere, including these forbidden areas. And you will guess what is the next slide. Of course, the most vital organ, if I understand. With applications that came little by little, such as interstitial syndrome and what to do after, and all this escaped to the good friends, radiologists. So the blue protocol was born from this, acute respiratory failure, and then the Sesame protocol for cardiac arrest, as we saw, one first step, with no look to the heart in the first 4. Then came the false protocol, that is a protocol for the circulatory failure, that we will not comment. We had to publish all that. And it was extremely urgent. And then began the war, a trench war. Each manuscript was, as you know, if you publish, rejected all the time, and we had to be strategical, publish this first, because if you, etc. There's a ceremonial. When I receive a decision letter, it stays on my desk 3-4 days. I gather my family, we make a party, and at the dessert, my children open the letter, and they read one and after the other, and one will give me the great news that is a good news or a bad news. That's my life. All these decision letters, some were positive, and the war is not finished. And each rejection was a disaster, a little bit for my life, but also I saw that the community has developed a tool that is great, and you save many, many lives, but it could have been a little more holistic because of all these rejections. The word that came the most frequently in our negative decision letters was, we have the X-ray, we have the CAT scan. CAT scan is 10 seconds, ridiculous. Look at this B profile. In the blue protocol, it is anterior and indicates the hemodynamic pulmonary edema with a 97 sensitivity, even if we have no cardiac window. This is the A' profile, indicating pneumothorax, imaged pneumothorax, with 100% sensitivity. That's the ADR of 1982. A perfect machine. The C profile, which is anterior by definition, indicates pneumonia with 99 specificity. So imagine how it can impact the world of pediatrics and neonates. Here we have an A profile that is anterior by definition, and to the right you can see a very scary deep venous thrombosis. Look how it comes to the heart at each diastole. The patient is really in high danger, and we have a 99% specificity for embolism in these patients without window, without cardiac window, or before looking at the right heart. So how can we make critical ultrasound a holistic discipline? If we include the lung in the traditional emergency ultrasound, if we give to the lung a place that is the place of the main vital organ, ex aequo if you prefer, and if you use one probe, you will see how the work is more holistic. Imagine that you have resuscitated a hypovolemic cardiac arrest who had the A profile, so you gave a lot of fluids. It was bleeding, so you risk the heart, and you want a venous slide. You will, of course, take the vascular probe, of course. But look the shape of this probe. It's linear. This area is not linear at all. We are not linear. So look just how we do. We take this microconvex probe, and we see the subclavian couple in the short axis. We turn the probe to the long axis of the vessels, and we have a nice vision of the subclavian vein. Perfect. And now we just have to take the needle, that is a factitious procedure, of course, in long axis, as you can see, and you just have to see the needle, that is a familiar image today of the needle coming into the target. Published 1991. And you can see that to the left upstairs, you can see a dilated right ventricle with that microconvex probe. Upstairs right, you can see a diseased lung with microconvex probe. Upstairs, no, downstairs down left, we can see that the catheter is in the jugular vein. And you can see here that there is an ectopic pregnancy with bleeding. All this with the same probe. So I suppose we have some time. That's, to my opinion, the probe of the critical care physician, which is not a minor discipline. And we wrote all our books, including the last one, with that only probe, and all our articles, and without any Doppler assessment. We use simple technology. This critical ultrasound is today a craze, a revolution. Some doctors, I heard, sleep with their ultrasound machines. I can understand. I could do that, but my wife would not be too happy. You have seen that the revolution was not the fact of the laptop machines. These US, I keep cautious, manufacturers, you can admire and thank them, but we could do the work far before, and I allow myself to say better. This image is better than 100 words. The machines must be small, tiny. And the disruptive revolution was the wheel, which allows you to move a heavy machine. That was disruptive. So holistic ultrasound is not just a new technique. It is also, I think, a philosophy, non-invasive, and all the advantages that you know perfectly. We have, in the last minute, a quiet revendication, which is not to have made works on lung ultrasound, but maybe in this night of 1985 to have given ultrasound from the radiologist to the physician hands, that is you, by the way. And I hope that this past, which is my present, will be your future. And we work on that. And the future is near. I like to thank especially my good friends, Luis Paredes and Jeff Handler, because they facilitated our presence here at the SMAC. I thank you deeply. It's great to be here. Thank you.
So who would have thought lung ultrasound would be like an action movie? But thank you very much, Daniel. We have got time for a question, I think, David.
Okay. Daniel, that was great, and I think it was mentioned by several people that they were very happy to hear someone speaking in not their native tongue. That was very recognized. One of the questions that came up was, you're a pioneer. What advice would you give to people who want to change the world?
In about 20 seconds, Daniel.
Yeah, in like 10 seconds or less.
In 10 seconds, I would say, look at my work. Begin very young. That's all I can say.
Thank you again, Daniel.